Good to be with you all today. I'm Van Ingram. I'm Executive Director of the Kentucky Office of Drug Control Policy. In Frankfurt, they don't pay you a lot of money, but they give you really long titles. So we got that going for us. I've been with this office 20 years. Before that, I was a police chief in Maysville, Kentucky. But glad to be here in Corbin today. The mayor kind of got out on me. Are there any people from Corbin in the room? Can anybody explain to me why my son lives in New York City and the traffic is worse here than it is there? Last week, I was coming back from Middlesboro. I was 20 minutes or so getting from the edge of Corbin to the interstate. I thought that was pretty bad. This morning, it took me 20 minutes to get from the Hampton Inn to the interstate, about 200 yards. So we got to do something about this traffic in Corbin. But it's good to see so much activity going on here and so much growth in this area. We're going to talk a little bit about where we've been, where we are with this opioid epidemic here in Kentucky. Can you advance the slides for me? Oh, here we go. So we go back over a dozen years. We really tried, was our first real attempts legislatively of trying to deal with this problem. In 2012, we passed a bill called House Bill 1. The interesting thing about that is the regular session had gavelled out and we didn't have a bill. We had fought all session to get something done about opioid prescribing for chronic pain. The then Governor Steve Beshear, Andy's dad, as soon as the legislature gavelled out, he called for a special session. There was only two things on that agenda, and dealing with this opioid problem was one of them. Now, the bill kind of got named the Pill Mill Bill, if you remember. It had 14 chapters in it, and only one of them dealt with pain clinics. But that when the media tags a name on a bill, then that's what you got. But really, the bill was about when a person is being prescribed an opioid for chronic pain, and they're going to be on that for a long period of time, that's a very careful and measured decision between a practitioner and a patient. That should not be a casual decision, and we all know that it was. We handed them out like they were candy. We were also the first state in that bill. We were the first state to do a number of things throughout this presentation, but we were the first state to require that pain clinics had to be either physician-owned or owned by a hospital. Why do we do that? Because we had truck drivers that own pain clinics. We had strippers that own pain clinics. They go on eBay, find them a doctor on Craigslist that would come to Kentucky. They'd stay in a motel. They'd see as many patients as they could in a day's time. By the time law enforcement figured out who they were and where they were gone. Never see them again. So there was no way to build a case on them. So we had to do something to make sure that whoever owned this clinic had some skin in the game. At that time, we had 76 pain clinics. When this bill passed, it had an emergency clause that it went into effect the day the governor signed it. 35 of them left in the middle of the night. Never saw them again. They didn't want the scrutiny. We required them with this bill to take third-party payers. They wanted to be cash-only businesses. They didn't want a paper trail. So we felt pretty good about that part of the bill. The next thing that we were the first state to do, we had have a program called CASPR, the Kentucky All-Schedule Prescription Electronic Reporting. We could only get about 25% of prescribers to use it. It's a great tool. We just couldn't get the numbers up. We tried everything. Then we made it mandatory. We said to prescribe an opioid, you have to check CASPR. The Board of Medical Licensure took it a step further and said, no, to prescribe any controlled substance, you have to check CASPR. Our doctor shopping has gone away because of that requirement. People aren't just going from physician to physician getting controlled substances. So we had a couple of firsts there. The next thing we did was in 2015 with Senate Bill 192, and really was largely a harm reduction measure. There were some stiffer penalties in there for heroin trafficking. That's true. But that bill created a Good Samaritan provision. Too many people had died of an overdose because the friends that were with them were afraid they were going to get arrested, so they ran. They left them in the hospital parking lot. They left them in a hotel. They left them in a car. This bill says if you call 911 and you stay with this person, if you've got a small amount of drugs or paraphernalia, you're not going to be arrested for that. We made that bill really clear that that Narcan can go to anybody. There doesn't have to be a physician-patient relationship for Narcan. I'm proud to say last year this state put out 160,000 dosage units of Narcan. But the thing that it really did, that a lot of you don't know about, is it allowed for syringe service programs. It allowed for syringe exchange. Now, if you'd have told me when I left the police department I was going to become a poster boy for syringe programs, I think I would have told you're crazy. But I did. I was approached by this Harm Reduction Coalition of America, and they said, Van, we'd really like for you to work on syringe exchange in Kentucky. And I said, we might have a Democrat governor at the time, but this is a pretty red state. It's a pretty conservative place. I don't think I can get that done. I talked to Governor Steve Beshear about it. He said the same thing. He said, I don't think you can get it done, Van, but if you all could try. So I went to John Tilley, who was then chairman of the Judiciary Committee in the House. And I said, I got this idea I'd like to float. He said, Van, I trust your research, but I'm going to do my own. So he had legislative staffer do some research for him. She came back and she said, Chairman, I'm a little upset with you. And he said, why? She said, because I knew syringe exchanges was wrong until I did the research. And now we know that people are 5 times more likely to get into treatment if they participate with a syringe service program. We know that communities that have them, needle sticks to first responders goes down more than 60%. We have better health outcomes in places where we have syringe service programs. So 2014, we put that on a bill. Secretary Tilley, or Chairman Tilley does. We had 18 amendments to take it off. Nobody wanted it. We came back in 2015, we tried it again. We went to a conference, what's called a conference committee, which means the bill stalled. And the bill had a number of things in it, syringe exchange just being one of them. And the legislature worked out a compromise. And that compromise was, first, your health department has to vote that they want it. Then the city where you're going to reside has to vote that they'll accept it. And then the county government where it resides has to vote that they'll accept it. I walked out of there and I said, okay, that's a nice compromise, but these communities are not going to do this. We'll get Louisville, we'll get Lexington, we'll get a couple of others. We now have 82 syringe service programs in Kentucky, more than any other state in the country. I'm so proud of our public health folks that went up, put themselves on the line and said, let me do my job. My job is to prevent the spread of disease. Syringe service programs help stop the spread of disease. And city commissions and city councils and magistrates and county commissioners said, okay, in at least 60 of our 120 counties. So I'm proud of that. We've still got work to do. I want one in 120 counties because I know they work. So we got a ways to go. We come back in 2017 with House Bill 333 and we addressed acute prescribing. And what we said in that bill was, for most things, a 3-day supply of opioids is going to be enough. There's exceptions to that, and we understand that, and we have exceptions built into that law. But we're really trying to reset the bar of people going in for minor procedures and coming out with 30 days worth of medication. There's a lot of research that says at about 10 days of opioid use, you start to get dependent on it. So we wanted to reset that bar with that bill. So let's talk a little bit about fentanyl, because that's really what's driving our overdoses here in Kentucky. It's not going anywhere. I want you all to understand that this is a model that's not going anywhere. We don't have a heroin problem anymore. We have a fentanyl problem. Here's why it's not going anywhere. for somewhere between $15,000 and $20,000, you can buy a kilo of fentanyl. Now let's add a little bit to that, and let's buy us a pill press. We can do that anywhere from $1,000 to a couple $1,000. That pill press will make between 75,000 and, I'm sorry, 75,000 to 100,000 pills. We sell those at $10 to $15 a piece. We've just made $750,000 to $1 million on our $25,000 investment. This ain't going anywhere. This is a business model that makes too much money for people. The cartels will never grow heroin again. They don't have to pay somebody to guard the fields. They don't have to take an agricultural product and turn that into a pharmaceutical product. Our government has pushed back on the Chinese government for years over their control of precursor chemicals, and it hasn't done any good. There's still plenty of it available. We're going to release a report here in a few weeks, a couple weeks. Governor Beshear is going to announce it. But the overwhelming majority of our overdose deaths, again, are fentanyl. So that's our enemy. That's what's killing our people. So, you know, we got a Medicaid benefit in 2014. And what that really proved is, if you pay for it, they will come. You heard Governor Beshear say on the video, we have more treatment per capita beds than any place else in the country. It's 70 per 100,000. The national average is 36 per 100,000. We're double the national average treatment beds. Very proud of that. But that really tells us we don't need to focus on residential treatment anymore. We need to focus on recovery supports. And we need to focus on recovery, removing barriers. So one of the first things I wanted to do when my office started getting a decent amount of money was remove the barrier of where do I go, who do I call, what do I do when I have a substance use disorder or my family member does. And I turned to my friends and partners at Operation Unite and said, I want to have a statewide call center. One number that we promote across this state, 833-8KY-HELP. Jamie, stand up a minute. Jamie and her crew, I'm going to give her a round of applause if you don't mind. Jamie and her folks do an amazing job. I get no complaints on this call center. It's amazing. And I didn't pay him to run it 7 days a week. Jamie came to me and said, I want to keep this open 7 days a week. I want to extend the hours, Van. She's done that twice. And I'm giving me more money. That doesn't happen in Frankfurt. Nobody volunteers to do anything extra with no more money, except Jamie and that team at Unite. So yeah, you can call that number between 7:30 and 10 p.m. Monday through Friday. It was 10 to 6 on Saturday and Sunday. 8:30 to 5:30 Saturday and Sunday. And they're going to walk you through that bureaucracy that is substance abuse treatment. Because we throw that word out there like it's all the same thing, right? There's intensive outpatient, there's outpatient, there's residential, there's partial hospitalization, there's medications, there's all kinds of stuff out there, right? They'll walk you through that. And they'll help you do it. They don't do an assessment, but they do a screening and they can do a referral and help you find the right program for you. The other thing we're proud of is findhelpnowky.org. You heard the governor mention that. We also have findrecoveryhousing.org. And 2 weeks ago, we launched findnaloxoneky.org. Great resources. Our partners at the Kentucky Injury Prevention Research Center at the University of Kentucky, we started talking about this about the same time we started talking about the call center. We heard from physicians and nurse practitioners and others, I'd like to make a treatment referral. I don't know how to do that. I don't know who to call. I can't stay on the phone all day. This website's kept up to date every day. You've seen these websites that are put up, and 6 months later, if nobody's updated them, they're not relevant. Kiprick keeps this up every day. And it's like the Expedia of drug treatment. A few clicks of a mouse, and you can find out what's available, where it is, and the payer source. Great resource. And Find Naloxone now is Please go to that website, because the more clicks we get on it, the higher up the Google chain will go, right? So please go to that website. That website makes it clear that we'll get naloxone to anybody. We'll mail it to you free of charge. Naloxone saves lives, and I'll talk about that a little later on. But we've worked with public health. We worked with everybody of us in state government that buys naloxone. We go through the Kentucky Pharmacists Association, and they purchase it and ship it out. So we know where every dollar goes, where every box of naloxone goes in the state of Kentucky by working together. We have a treatment stipend program. Guess who else? Operation Unite Again runs that program for us. Where's Dawn? Stand up, Dawn. Dawn does an amazing job with our treatment stipend program. Let's give her a round of applause as well. So in fiscal year 21 alone, we had almost 13,000 people. You talked about qualified health centers, and we've leaned on our FQHCs to do more prescribing of buprenorphine and Suboxone, because we know you'll do it right. We know you'll do it the way it's supposed to be done. We've put on free data waiver training. We've developed bridge clinics at a number of hospitals. Appalachian regional hospitals here have done some. There's one in Harlan, where when people come in with an overdose, we can begin treatment with buprenorphine till we can get them stable and get the right treatment program for them. It's a bridge clinic. It's a bridge to keep them from leaving that hospital, because what's the first thing you want to do when you've been put into precipitated withdrawal? You want to go use again. We hope to prevent that with this program. Quick response teams. We now have about a dozen of them around the state. They go out after a non-fatal overdose to let people know we're here. We love you. We care about you. We can help you. Does it work every time? No. Does it work most of the time? No. Does it work some of the time? Yes, and that's what makes it worth doing. Our KSP Angel program. We started that with a kickoff meeting in Pikeville almost 8 years ago now. People said, nobody's going to come to the state police post and say, I need help with my drug problem. Well, over 200 people have. I was in law enforcement for 24 years. To a lot of poor folks, we're the only resource they got. Think of what other agency you could call, state or federal agency you could call, or local agency, and we come to your door and say, how can we help you? That's what law enforcement does. And a lot of people, a lot of poor folks, we're who they call when they need something. So we're really proud of state police in that program. We've done Casey's Law trainings all over the state, and we've increased the amount of Casey's Law use in every county in Kentucky. I talked about syringe service programs, so I won't go back into that. We've done Core 12 trainings. What we find is, if you give people the choice of when they come into a program, do you want to go be abstinent? Do you want to be on buprenorphine? Or do you want to be on Vivitrol? It's about a third. It's really not much difference in what people would choose. It's kind of balances out. We worked with EKSEP. Is anybody here from East Kentucky Concentrated Employment? Well, we worked with EKSEP to place a person at every one of our career centers in Kentucky to focus on linking people in recovery with meaningful employment. You know, when you come out of a residential program and you're young in your recovery, if there's, and today didn't look so good, we didn't have a job, we didn't have a way to pay the bills, and tomorrow there's no hope that tomorrow's going to look any better, it's easy to slip back into use. We got to give people hope. And what's one of the things that define most of us? It's our job. It's what we do. We all get something from that. And folks in recovery get a lot from that. So we're doing everything we can along those lines to link people with jobs. And in 3.5 years, 12,000 people served, nearly 7,000 jobs retained. So the program works. And we just renewed a contract with them this year to keep it going. I've partnered with the Kentucky Chamber, and I've granted them some money for the last 6 years. So you all know I've been collecting a government paycheck since I was 19 years old. I have no credibility in the public sector, or the private sector, I'm sorry. Nobody's going to listen to me in the factory that says you need to do this or you need to do that, because I don't know. Chamber knows. They listen to the chamber. So we partnered with them, and we've trained thousands of businesses across Kentucky why you need to be a fair chance employer. We have these fair chance academies. We're going to have one in Harlan next month. We had one in Elizabethtown. I forget where else we've been, but we're traveling around Kentucky. Berea, we were in Berea a few weeks ago. Just one day to invite employers in and say, here's the reasons why you need to be a fair chance employer, and here's how we can help you do it. We have a 3-day academy in Frankfurt that we invite folks to come to, and it's very intense, very in-depth. But we started this on the road project just so we come to you. Instead of you having to come to Frankfurt to us, we'll come to you. If you'd like to have one here in Corbin, let me know, and we'll set it up. And like I say, we are going to be in Harlan next month. But really proud of this program. We've trained thousands of business leaders, and we've gotten thousands of people connected in jobs because of it. We started something a few years ago with some grant money. We took 5 probation and parole officers and sent them to training to become job placement specialists. The program was so successful, SAMHSA, our funder in DC, said, we want to double it. We want you to have 10 instead of 5. My office now pays for that program, because like all grants, they run out, right? But we've proven that we can connect our inmates leaving the institution with jobs if we have the right people to do it. So that's an award-winning program we're really proud of at Department of Corrections. And a grant came across my desk this week, and we're starting to write another federal grant for more activities like this. In a minute, you're going to hear from Jonathan about recovery housing. As I travel every corner of this state, 2 things come up everywhere I go. We need certified, competent, sober housing, recovery housing. Because we got some places in this state that have called themselves sober living that were anything but. So Jonathan has done a lot of work and continues to do a lot of work to shore that up and see that when you go to a recovery house in Kentucky, that it's certified and it's up to the standards that it should be. So we put some money into that. We've encouraged our community mental health centers to think about running sober housing, because I know they'll do it right. I mean, we've had a few to take us up on that. And then my office grants money to organizations or facilities that take care of pregnant and parenting women with an opioid use disorder. So we've encouraged them with our grant money. Let's keep people longer. Let's keep mom and their kids as long as we can before they have to go back out. Coming out, again, we talked about this, that thing with jobs. Housing is crucial too. If you come out of a residential program after 30, 45 days, and you go back to the exact same environment you came from, temptation's awful great to fall back into old habits. The second issue I hear about all the time that we're working on but have not figured out a good solution is transportation. There ain't a lot of bus service in Corbin. There's no buses in Boonville. There's no way to get around. And everybody can't afford a car, and everybody can't afford gas for a car. So it's a real problem. We're working on a number of ways. In a previous administration, I had to do a lot of work with Medicaid. So I learned a little bit about Medicaid, more than I ever wanted to know. Trust me, there's a special place in heaven for people who've worked in Medicaid. It's very complicated. But I learned that in every one of our counties, there are transportation providers that Medicaid pays for. So I approached the transportation providers and said, if we pay you, will you take our people that are on probation and parole and get them to their treatment appointments and get them to their job interviews and get them to their meeting with their parole officer? And they said, sure. So we continue to operate that program around the state. Funding is about out. I got enough money to keep it going for another year or so, but it's been a very successful program because a lot of our folks coming out of prison don't have driver's licenses, don't have cars, but they have places they're supposed to be. And so we've used this program to do that. I just mentioned the transportation pilot. We've done a lot of peer support training around the state. Through our core program, we've paid for Too Good for Drugs curriculum to any school system that wants to teach it. And almost 1 million kids now have been exposed to the Too Good for Drugs curriculum. So when people tell you there's no prevention in Kentucky, yes, there is. There's lots going on prevention. You may not see it, but it's there. Sources of Strength, another great program that we'll pay for any school that wants to teach it. We've worked with our Kentucky Hospital Association for opioid stewardship. We continue to bring the prescribing numbers of opioids down, and that's a good thing. And we appreciate our work with the hospitals to do that. I want to ask Sue to stand up. Sue Fox, Recovery Ready Communities. You heard the mayor talk about that. Sue and her partner, Dallas Hurley, run this program for my office. I have found over my 20 years in state government, it's a lot better for me to hire somebody to do something I need done than hire state employees. Here's the thing. Once you get a state employee, you kind of got them for life, whether they're working out or not. When I have a contract with somebody, I can end that contract in 30 days if I need to. I don't need to. Sue and Dallas have done an amazing job. Thank you. So the Opioid Abatement Commission, how many of y'all heard of that? Okay. So the opioid settlement money that came to Kentucky, 50% of it goes directly to counties and cities. The other 50% goes to the Opioid Abatement Commission, housed in the Attorney General's office. I was appointed to that commission by General Cameron and have been reappointed by General Coleman. In the first year, we awarded $49 million on 59 grants. Another program I did in 2023 was I took some federal grant money and worked with 39 prisons and jails and said, anybody that comes out that wants Narcan, we'll pay for it. If they'll take it, we'll pay for it. I ran out of money after about 13,000 kits were handed out. But we feel like giving out Narcan at county events and Walmart was good to get started, but now we need to really get it in the hands of people most likely. I mean, I've carried it since 2015, right? I go out to eat one night a week and I'm home by time for Jeopardy. So I'm probably not going to run into anybody in an overdose. So we need to get Narcan more in the hands of people who are likely to have that. So Sue and Recovery Ready Communities, they've certified 10 counties. They have at least 4 pending, or how many you got pending, Sue? 4 pending and 7 site visits yet to do. So the goal I set for them was 10 in 2024. They're going to surpass that. So that's great. And hopefully Corbin will be one of those. Let me tell you about Senate Bill 90 as we're getting close to wrapping up here. Senate Bill 90 passed a couple of years ago. It's a pilot program where when people come in on a qualifying charge, a lot of misdemeanors and some low-level felonies are qualifying charges. That we'll give them, if they qualify, we'll give them an assessment within 72 hours of arrest. If that assessment shows that they have a mental health disorder or they have a substance use disorder, we'll offer them the services they need, treatment, education, vocational training, whatever is needed to get this person life turned around. And then when they complete that program, the charges will be dismissed. What we're trying to prove in these 11 counties we're doing this pilot in is having people lay in jail, play cards, and sleep all day is not going to get us anywhere. It's just not going to work. It hasn't worked yet. We've been doing this for 100 years. But maybe if we get people the services that can help them over the hump, that'll be a better use of our money than filling up our jails and prisons. So I told sponsor of this bill, Senator Westerfield, when it was being drafted, I said, bills in Frankfurt are nice, but if we don't have somebody implementing them, they often don't work. So he put together an implementation team and then made me chair of it. I said, that's not what I meant. I wasn't looking for a job. I was trying to give somebody else one, but I didn't want one. But we've been running this program now for a little over a year. Our star is Letcher County. Judge Mullins over there has done an amazing job with the program over there. And so we're going to try to prove that this is a better way, a better mousetrap. Tell you something interesting. Of the 200 people we treated in this program in 2023, only 12 had a substance use disorder alone. The overwhelming majority were co-occurring mental health disorders and substance use disorders. We've got to start looking at how we treat these things differently. Just the old model of only addressing their substance use issues is not enough. We've got to dig deeper. That's my contact information. If you have a good idea, call me. I'll implement it and say that I thought of it. But I'm glad to do that. I've done it for years. I've got 2-3 minutes left. If anybody has any questions, I'll be glad to entertain them. If not, thank you. I'm glad to thank you for being here. Governor Beshear is going to make an announcement in a couple of weeks of some really good news on overdose fatalities. That doesn't belong to any agency in Frankfurt. That belongs to every community in Kentucky that's addressed these issues. Because this battle is not going to be won in Washington, D.C. It's not going to be won in Frankfurt. It's going to be won in Corbin, in London, in Somerset, and Hazard. That's where real change happens, at the community level. That's where all real change in this country has always happened, at grassroots level. And it's going to take community at a time to beat this epidemic back. So thank you for the work you're doing. I appreciate you being here. Godspeed. Good luck with the rest of the day.